All right. Good afternoon. Can you hear me? If you can hear me, somebody should say yes, sir. If you can hear me, somebody should just type.
Yes, sir.
Yes, sir.
Good. Please, just type yes, sir. Type yes, sir, if you can hear me. Unmute your mic. Unmute your mic, please. All right. Good afternoon. You are welcome to our today's class. Today, we'll take a look at AUM 221, Action and Uses of Medicine. Action and Uses of Medicine. Okay, in our last class, we discussed drug nomenclature. In our last class, we discussed drug nomenclature. So in that class, we started with the meaning of what drug nomenclature is. We introduced it, and we discussed a lot of things, and I think we stopped at issues with respect to. Please mute your mic, 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 mute your mic. Miracle Sisi, Bakare, mute your mic.
Good afternoon.
Mute your mic. Susie, mute your mic. Thank you. All right, so we discussed, let me just run through what we discussed in that class. We talked about what drug nomenclature is. We discussed the three basic categories of drug names. Here we discussed chemical name, brand name, and generic name. And we talked about different authorities. We talked about the IPAC, talked about the WHO INM program, USAN, and the one by Britain. And we talked about the INN stems, where we talked about different stems, different suffixes that we use to, identify different classes of drugs. We talk about the olol, pril, satan, statin, prazole, saline, azole, and we talked about statin, for example, now simvastatin, atorvastatin, that lower the cholesterol, the blood cholesterol level, bringing it to normalcy. So I will not go back there again. Please, there's a recorded lecture to this effect. Please listen to that lecture so we don't waste our time going to and fro. And we talked about we compared trade names and the generic names, and talk about the importance of prescribing drugs using the generic name. And we talk about the bioequivalence and when to substitute and when not to substitute, when to call the attention of the physician, and when to call of course, you always call the attention of your pharmacist, because you are working under, as a pharmacy technician, you are working under this supervision of a trained and a registered pharmacist. So you work under the pharmacist. So you always speak to your pharmacist. So the pharmacists know when to substitute and when not to substitute. Then we talked about the concerns with respect to naming and how to avoid the look-alikes and sound-alikes. So we should be very careful with that. We discussed that. Okay. So today we look at another thing. I want us to answer some questions, but let's just answer a few questions, if a kind of review. So I'll ask a question. If you know it, just unmute your mic and answer the question, then mute your mic again. So question number 1 says, you know, your exam is CBT, so try to be conversant with this question so that we'll be able to answer them. Remember, I told you that your CBT questions has to do with the options. Sometimes the options may be the same, maybe almost the same thing. So all you need to do is to identify the most appropriate option. Okay. So number 1 question says, I don't know if we answered some questions in our last class. Did we? I think we did. Did we? Please.
We did, sir.
We did.
We did.
sir.
All right. So good. Let's go to the next question. Let's go to the next topic fast. No time to waste. All right. The next topic I want us to look at is routes of drug administration. Let's look at the routes of drug administration. The one you call routes of drug administration. So let's look at the routes of drug administration. So by the end of this lecture, you should be able to define routes of drug administration and explain why you choose a particular route of drug administration, why the choice of route of drug administration matters. You should also be able to classify the major routes of drug administration, things like enteral versus parenteral, local versus systemic, and you should be able to give typical examples and indications. And you should also be able to describe the pharmacokinetic consequences of the route of administration you select. Things like the onset of action, duration of action, and bioavailability, and first pass effects. I believe you did first pass effect in your AUM 122. Now, then you should be able to list the advantages and the limitations and key administration cautions for each of the routes of administration. So this is now more practical, we are talking about what a pharmacy technician must know and communicate. Now, without wasting time, let's go straight to the topic, route of drug administration. Please, can someone tell me, what do you understand by the term route of drug administration? All right, someone should unmute your mic and tell me, what do you understand by the term routes of drug administration?
Good afternoon, everyone. So, to my own knowledge, route of drug administration simply means the way or the process of which drug is taken. The way drug is taken, I mean the route, the process of which drug is taken.
Hello,
Mute your mic.
Good afternoon, sir.
Another person, please.
Good afternoon,
Good afternoon,
sir.
everyone.
Yeah, good
My
afternoon.
own little understanding of route of drug administration is the path by which drug enters the body to produce its effectiveness.
Can you hear me? Can you hear me clearly?
Yes, sir.
Clearly.
Yes, sir.
Yes, sir.
Good. Okay. And the second person, I like that. Another person, please. Another person. Another person.
Good afternoon.
Please. Only the person asking questions should unmute. The others mute your mic, please. Okay, continue. Continue.
Good afternoon, sir.
Yeah, good afternoon.
Yeah, route of drug administration. It simply means how the drug is introduced into the body, how drug is being introduced into the body via
Okay.
orally, suppository, pastries, or any other route.
Okay, good. I like that. All right, so route of drug administration can be defined as a path by which a drug is taken into the body for diagnosis, prevention, cure, or treatment of diseases. Are we together? So that is what route of drug administration is. Is the path. Is the path through which drug enters the what? The system. So that's what drug administration means. Okay? Good. Now, route of drug administration actually affects, please mute your mic. Route of drug administration actually affects how much the drug reaches to the systemic circulation. That is bioavailability. So route of drug administration affects the bioavailability of a drug. So if you want optimum bioavailability, you should be able to choose the right what? The right route of what? Administration. Not only bioavailability, route of drug administration also affects how fast, how quickly that particular drug acts. That is, we are talking about the onset of what? Action. How quickly it starts acting. Onset of action. Route of drug administration also affects how long the effect of the drug lasts in the body. That is the duration of action. So, if you choose the wrong route of drug administration, it will eventually affect, in fact, it will eventually reduce the efficacy of the drug. It can also increase the harmful effect of the drug or the toxicity of the what? The drug. So you have to choose the right choice of what? Drug what? Administration. Are we together? Are we together? Any question? Any question? All right, so let's proceed. Let's proceed. So it's very, very important you know this. So practically, for a pharmaceutical technician, you should also know that the route of drug administration determines the what? How your labeling will look like. So it will determine the storage, even how you counsel your patient, even the monitoring, how to monitor the therapy, even what you are going to document. And sometimes in emergency situation, it also determines whether the medicine will act fast enough. Now, if you have a patient that is rushed to the hospital, the patient is unconscious. I'm asking a question now. A patient is rushed in the hospital and the patient is unconscious. Now tell me, do you think even though we have not discussed the different routes of drug administration, but I want to test your residual knowledge. Tell me, what route of drug administration do you think the patient needs at that point in time? A patient that is rushed to the hospital and the patient is unconscious, and they have actually determined what to treat. But the issue now is, what is the route of drug administration that the patient needed at that point in time?
Intravenous.
No,
Intravenous, sir.
intravenous. Intravenous
Why not?
or intramuscular.
Why not oral?
Because the person is unconscious, so there will not be a way to pass it into the person's mouth.
God
And
bless you.
It's not be
bioavailability of
convenient.
oral drug is not as active as intravenous.
God bless you. Good. Now, so have you now seen how the route of drug administration will affect a lot of things? Have you now seen how it can affect a lot of things? Good. So now let's go to the next thing I want us to discuss. Let's look at the classification. Let's look at the classification of routes of drug administration. The classification. It can be classified in different ways. It can be classified in two broad ways in terms of local versus systemic. It's a classification. We have a local route. There are routes under local administration, and there are some routes under systemic administration. Then there are also some routes under enteral administration, and there are some under what? Under Terra. So let's look at systemic, local versus systemic. What do you understand by the term local? Local routes and systemic routes. Can someone speak to us? What do you understand by the term? If they say that a drug is acting locally or a route is local, tell me what you understand by the term that a route is local, and give me example, and what you understand by the term that a route is what? Systemic. Let me hear you. Share with me.
Sir, to my own understanding, I feel like local route, this is when the drug is applied to the site of, I don't know, site of administration, like is applied locally.
Yeah, isn't the same
And for
term?
example, like the ones we have for external, like our 7 keys, maybe if it is applied on the skin, so it's applied locally like that.
Okay. What about
Sir.
systemic?
Okay.
I'm listening.
Good afternoon, sir.
Yeah, good
Uh,
afternoon.
look, when local route of drug administration is when drug is applied, when the drug is applied at the site of injury or site of ailment, like topical, something like
Okay.
that, when it is applied on the site. Why systemic is when it passed through the bloodstream for results and stuff like that.
Okay. Good. Good. Please mute your mics, please. God bless you, Chisom. Um, good. I like that. Now, if a drug is applied locally, what it means is that that spot you apply that particular drug, that is the where it's acting. Is that clear? Maybe if you have a spot on your skin or a skin a skin condition and you're looking at it, maybe SM or something, you're looking at it, you get topical cream, maybe cream, antifungal or whatever, and apply at that spot. Your mission is for it to work at that spot, for you to take care of that particular effect at that spot. What you are doing is what? You are applying it locally. It's a local application because you want it to have a local what? Effects. Now, but when you maybe administer a drug, it will now enter, it's not, if you get a tablet now and swallow a tablet, maybe paracetamol, the paracetamol you swallowed, that paracetamol is not acting in your mouth. The paracetamol will enter your stomach. It's not even acting in the stomach. It will get disintegrated in your what? Stomach. When it gets disintegrated in the stomach, it will be absorbed into the bloodstream and go to other part of the body where it is needed. That route is a systemic route. So oral administration can be local because there are some that you put in the mouth, like nystatin now. If you get nystatin oral suspension, maybe for oral thrush, and locally in the mouth for oral thrush, in that mouth, that buccal cavity, that one is not systemic. It's acting there in the mouth. Am I communicating? Then if you get something like Bonjela, maybe someone has mouth ulcer, the person applied Bonjela in the mouth. That one is not systemic. It's locally. Someone that has suppository, maybe the person has pie, anosol suppository, the person now insert it. It's acting locally. It's not systemic. It's not systemic. Even diclofenac. Diclofenac can also be taken, used locally, and it can be used what? Systemically. You can swallow diclofenac tablet, it enter and get the disintegrated and enter the bloodstream. Systemic. You can apply diclofenac on the, maybe if you have musculoskeletal issues, maybe you have joint or pain there, you apply it there, it will take care of or inflammation. It will apply locally, it will take care of it. So this is what we mean by what? Local application and what? Systemic what? Application. Now, for local effects, drug, as I said before now, the drug is applied directly to the what? Site of what? Action. Example is your what? Topical what? Cream for skin infections or conditions. And the example is your eye drop. Your eye drop is another example. Yes, if you apply topically on your and locally, sometimes a little systemic absorption may take place. Yes, that's why you should be very, very careful with the type of cream you take. Be very careful about the cream you take, because the cream you take can actually find its way into systemic what? Circulation, and the content may harm you. It may harm your internal what? Organ. The content may harm your what? Internal organ. So be careful about the cream. Before you take any cream, look at the content of the cream you want to take. If possible, avoid them if you can. If you cannot, be careful of the type of cream you take, because it can affect you internally. So in every local application, systemic effect is expected to some extent. So if you understand this now, it will help you to maximize this local effect. It's help to maximize the local concentration and minimize what? Systemic what? Side effects. That is the main, there are some drugs that they may have their systemic effect may side effect may be much, but if they are formulated as for local effect, so that they will focus on that particular place they should act. In fact, if it is possible, if you want to treat a particular ailment now, and there is a topical application for that ailment, and also there's a systemic, and actually the topical, if you apply it topically, it will work. I will always advise you go for topical application, because it will minimize the side effect when you apply it topically than when you take it systemically. Are we together? Are we together? Hope you can still hear me. Huh?
Yes, sir.
Yes,
Good.
sir.
Yes, sir.
Good. Now,
Yes, sir.
good. Now, so have you now seen that some routes now can be under local routes because of their effect? Now, can you, from this describe now, can you give me some examples of route of administration under local?
Glycogel.
You say what?
We have the topical, sir.
Okay. Topical, under one.
Nasal.
Good, under one.
Otic.
Under one. God bless you. Under one. Otic is here.
Vaginal.
Good, under one.
That's all I know, sir.
Okay. What of systemic?
Oral, sir.
Oral.
Oral.
Intravenous.
Oral, right?
Intramuscular.
One person at a time, please. One person at a time, please. One person at a time, please. So don't. Okay. Taiwo, I'm listening. Bakare.
We have the sublingual and buccal.
Sublingual. Okay. Buccal is not systemic. Buccal is not systemic.
We have the rectal too. Rectal.
Rectal.
Yes.
Yes. Some rectal can be systemic. Some some can be local. Some rectal can be systemic, some can be local. Continue.
Okay, sir. Inhalation.
Inhalation.
Yes, sir.
Inhalation.
Under systemic route.
Okay. Another one.
Parenteral.
All right. Thank you very much. Thank you very much. I am I am impressed. I am impressed that you guys are ready for this topic. Now, for systemic, now we said that the drug must be absorbed into the bloodstream, then distributed throughout the body to be able to reach to their site of what action. You have listed a lot of them, and what you listed are in order. But we will see have the list too. But I just want you to understand where we are coming from. Now let's go to the next, the other routes, the other classification. We have the enteral and what? Parenteral. Enteral and what? Parenteral. Please, anytime you hear enteral, it talks about that the thing must pass through the gastrointestinal tract. Please note that. Anytime you hear enteral, the drug must pass through the gastrointestinal tract. Or if you go back to that, your secondary school biology, they call it what? The alimentary canal. It starts from the mouth and end at the what? Anus. That tube. That's tube. Whatever passes through that tube, from the mouth down to the anus, what passes through that tube is known as what? Enteral. So enteral. Are we together? So now it will enter through the mouth. It will enter through the mouth. Please note that point. It must enter through the mouth or through the rectum. Either of them is enteral. Are we together? Through the mouth or through the rectum. So we have things like sublingual route, we have buccal route, we have rectal route. All of them are under what? Enteral. They are under what? Enteral. They are under what? Enteral. Good. Then we also have the parenteral routes. This one, the parenteral route is not through in fact, any other route apart from what I've just said about enteral is under what? Parenteral. Any other route that is not gastrointestinal, from the oral cavity down to the what? Anus, is not enteral. It's parenteral. Parenteral. That is not enteral. That is the meaning. Not what? Enteral. Are we together? Not what? Enteral. Now, examples, you see things like all injections. Injections are administered through what? Parenteral route. You have the IV intravenous, IV intravenous. You have your what? IM intramuscular. You also have your SC subcutaneous. SC subcutaneous. Then you also have the ones that are not even that are not intravenous. We have intrathecal. We also have intrathecal. Intrathecal is where? Who can tell us? Intrathecal, where is it targeted? Intrathecal. Who knows? Intrathecal, who knows?
Sir, it's under the skin.
Intrathecal?
It's under the skin, sir.
No. It is subcutaneous that is under the skin.
Oh,
Intrathecal is where?
Through the lap.
Surrounding the spinal cord. It's around that spinal cord side.
God bless you. Don't worry. We'll still talk about it. I just want to prepare your mind, okay? So if you don't know it, don't worry, I will discuss it. All right, so we have intrathecal, we have inhalational. I think some mentioned inhalational now. Then we have intranasal, we have intranasal. Then we have transdermal patch on the patch on the skin. Then we have our topical, we have ocular, we have otic. All those ones are not enteral. Are we together? Now let us now go deeply into enteral routes. Let's look at the enteral routes. So the first one I want us to look at under enteral routes, I want us to look at the oral. Remember the abbreviations I gave you in your first year, if you can remember, prescription abbreviation. Can you remember that? Where I gave you PO. PO is what? PO is what?
By mouth.
What is the meaning? PO.
I think it's per aura.
God bless you. Per
Okay.
aura. Per aura.
Per aura.
Yes, God bless you. Per aura. Okay. Per aura. Good. Okay. Now let's go. So how does oral administration goes? So per oral, we swallow, if you swallow the tablet, it will enter the what? The stomach. Then it will do what? It will get disintegrated. Then it will get to the what? The intestine. There we have the absorption. Of course, if it get disintegrated, dissolution will take place. Then just the same way your food get absorbed, the drug will also be what? The drug will come out from the medicine. The drug will come out from the medicine during dissolution. It will disintegrate. During the dissolution, the drug will come out from the medicine, from the dosage form, and gets into the what? Across the what? The GI mucosa, and now enter the what? Through the capillary bed there in the walls of the intestine. It will enter through the capillaries to the what? The drain to the what? The portal vein. From the portal vein to the liver. Of course, when it gets to the liver, some of them we get degraded, metabolized through the process of we call first pass metabolism or first pass effect. Not all the drugs are. Then when this happens, then they will go back to they will return to the systemic circulation, and they go to their various point of what? Set of what? Action. So this is basically, we are not discussing the pharmacokinetics, but I just want to let you know what actually happened through if you take drug orally. Now, what are the advantages of this oral administration? What are the advantages of this oral route of drug administration? The oral route of drug administration is safe. It's safe. And it is non-invasive. What it means is that you don't need to, puncture any part of the body for you to take drug. And it is convenient. It is convenient. It's relatively inexpensive. It is relatively inexpensive. And there are many dosage forms you can take through oral routes. Things like tablets, capsules, liquids. So there are different choices of dosage forms that can be taken through oral routes. Then what are the limitations? Does it have any limitation? Yes. It has a slower onset of action. Very important. It has a slower onset of action. So because it has a slower, because the drug will enter the GIT, disintegrate first, dissolve, absorb, pass through the portal circulation, get to the liver. Some may even get lost safe. But at the end, before coming back to systemic circulation, long thing. These processes makes it to have very slower onset of what? Action. So because of that now, it is not ideal for emergency situation. Remember the first question I asked you. It's not ideal for emergency situation. Then another issue that it has variable absorption. Two of us may take the same tablet at the same time. I may get healed from my illness. You may not get healed because our absorption, there are different factors that affect absorption. Your absorption, in fact, there may even be no absorption in your case too, because it also depends on the nature, the situation, condition of the GI, of your GI. My condition of my GI may be better than your own. Food presence in your GI may affect your own, in your GI may affect your own absorption. In your stomach may affect your own absorption. Yes. The type of food you eat may affect your own absorption. The type of food I eat may even enhance my own absorption. The pH of the GI may affect absorption. We discussed this extensively in your ability 152. Then your motility, the motility of the movement, the peristaltic movement, the movement of your GI muscles, motility will also affect your own absorption. So this whole thing, have you now seen why I say that the oral as a limitation, oral route of drug administration have variable what? Absorptions. So because a lot of factors may affect it. Then some drugs on their own, apart from the biological, the physiological state condition of the GI, some drugs on their own can be destroyed by the gastric acid. The acidic content, acidic nature of the stomach can destroy some tablets, some drugs that are administered orally. Apart from the gastric juice, even enzymes, some enzymes can destroy some drugs. So that's why before you formulate a drug, find out the right way to formulate it. The right way to formulate it so that it can resist the enzymes and the acid content of the stomach. I've talked about the hepatic, the first pass effect in the liver. So this whole thing can affect drug administered orally. So that's why before a physician will prescribe a particular drug to be administered through a particular route, this whole thing will be put into consideration. We have given extensively examples. Most analgesic you see are taken orally. Even antibiotics orally, even though we have the one that will take parenterally, but a handful of them are taken orally. Even some antihypertensives. You see your tablets, suspension. You see tablet amlodipine, tablet what is it called? Synoprin, God bless you. Telmisartan, right? Many of them. Vasoprene, all those things can be taken even though vasoprene is not antihypertensive anyway, but it's taken orally. Yeah, antibiotic, you see tablets, you see suspension, many of them. So these are taken orally. They are taking orally. All right, so now, so you as a pharmacy technician, what are you supposed to be look out for? Please, when you are administering, maybe because tomorrow you may see yourself in a place where there's no pharmacist. So I don't just train you as just a robot. I try to train you in such a way that tomorrow there are a lot of my students that are working in different places now. Some places that are working, the pharmacist is not there. In fact, some pharmacy, because of the confidence, because of the type of skills they show, in fact, some pharmacies even allow them to do certain things because they have proven themselves. So you don't know where you see yourself tomorrow. You may be employed in a place that there's no pharmacist. That means the doctors will rely on you. So you have to be well equipped. Very, very what? Important. So check out as you dispense or hand over the medicine to the patient, find out the food. Whether the food to the patient should be able to take with a particular drug. Like now, a patient that is taking ciprofloxacin tablet orally, ciprofloxacin have no business with taking it with what? Iron supplement, because iron will not allow ciprofloxacin to be what? Absorbed. So the bioavailability of the ciprofloxacin will go down because of the iron. What's going on there? Who is this one?
I'm going back kick my phone.
Okay, now, so you someone that is taking a antacid. You know that antacid will reduce the level of will neutralize acid level in your tummy, in your stomach. Of course, when happening, you know that this will affect digestion. So you don't need, some patients don't need to take food immediately after taking food. Immediately you take the antacid. You give gap. Yes. You either give you either give like 30 minutes before meal, 30 minutes to 1 hour before meal. You can take the drug, the antacid, or any anti-ulcer that affects the acid level in before the meal or 2 hours after meal, because be sure that the food are digested and left the system, and before you can now take it. In fact, they are better even taking it in empty stomach. Yes. Then you are taking a anti-malaria, like artemisinin containing anti-malaria. You can be taking it with antioxidants like vitamin C, specifically with vitamin C. It will mess up the artemisinin base combination. Artemethyl lumefantrine. Let me be specific. It will mess it up because it will destroy it. So it not be able. That's why some of you, after some of you use orange juice, or you say patient you using orange juice to take drug. What are you artemisinin containing antimalarial? What are you doing? So these are the things you should know as pharmacy technician. Then also there's some drug that you know that this drug can cause vomiting and the nausea or vomiting. Then you tell the patient about it on time. This one, in case it's not happening, so that you not be afraid, you know. So then if you know about all these things now, it will help you to be able to, like now, for a patient that has a patient that is vomiting, a patient that is obvious that the patient has is nauseating, and the person is nauseating or vomiting, will you go and give oral medication to the patient? Will you?
No.
Good. It will be a waste, right? It will be a waste.
Yes.
So have you seen the importance of knowing what you are, learning this thing, so that you know how to go take care of your patient? Now, another category under enteral route I want us to look at is sublingual and buccal. Please, sublingual and buccal is not the same. They are not the same thing with oral.
Yes.
So they are not the same thing. In oral, it will leave the mouth and enter the GI. the GIT. But in sublingual and buccal, they don't enter the GIT. They don't enter the stomach. No. Buccal is there in the mouth. Please mute your mic. So mute your mic. Mute your mic, please. So for sublingual is placed under the tongue. Are we together? Sublingual is placed under the tongue, while buccal is placed between the cheek and the gum. Between the cheek and the gum. Yeah. Between the cheek and the gum. While sublingual is under the tongue. Sublingual is under the tongue. Please note that, okay? Sublingual is under the tongue. Sublingual is under the tongue. Okay, let's continue. Now, so when you place it sublingually or buccally, what on the buccal cavity, they will be absorbed. Yes, apart from the local effect, they can also be absorbed across the oral mucosa into the systemic vein, especially for sublingual. So apart from the local effect, they also have systemic effects. So be careful. So they can pass through the oral mucosa and enter the systemic veins. They will bypass. That is where an advantage of this one. Maybe there are some drugs that you don't want them to enter the stomach. One, you don't want them to be affected by the enzymes in the stomach, the acid condition of the stomach, or you don't even want them to get to the portal circulation and get to the liver to bypass the first pass effect. Such drugs can be administered sublingually. They will bypass the first pass hepatic effects. So what is the advantage of this? The advantage of this, what are the advantages? Quick absorption, very important. Yes, they absorb faster than what? Oral one, yes. Quick absorption because they can be absorbed through the capillaries there and enter the systemic what? Circulation. Quick absorption. Quick onset of action, yes. Quick onset of action for certain drugs. So it is useful. It is useful when drug, as I said before now, when drug has the potential of being inactivated in the stomach. Please let's note this point. So what are the limitations? What are the limitations of this sublingual / buccal and buccal? What are the limitations? You cannot use this route to administer large doses. No. You cannot administer large doses of drug through this route. You can only administer small doses of drug through this route. Please let's note that point. Small doses. Another issue that it is unsuitable for, it cannot be used for drugs that are unpleasant, that have unpleasant or bitter taste. You cannot use it to administer such drugs. So it's unsuitable for drugs that have unpleasant or bitter taste. And why isn't it? One may mistakenly swallow it if you're not careful. Okay. You have a question? Okay, ask. Okay, ask. And they ask a question. You raise your hand. Is it by mistake? Please lower your hand. Please lower the hand if it's by mistake.
Okay.
Okay, don't worry, I've lowered it. All right, please. You raise your hand only when you want to ask a question. But it's better you wait. I'll at the end of every section, I'll always give room for questions. So we don't waste time. Okay, so it can only be used for smaller doses of drugs, and it's not suitable for drugs that have unpleasant and bitter taste, and one can mistakenly swallow it. Yes, one can mistakenly swallow it. Is a problem too. Yes. So now examples of drugs that are administered through this route. We have here nitroglycerin. Nitroglycerin can be if there are some, if sometimes they even this antihypertensive. What is the name? Who can tell me?
Nifedipine.
God bless you. Nifedipine, yes, can also be administered through that. Buccally, you can have your what? Buprenorphine can be administered buccally. Now, I think I mentioned anyway, let me not go there. Let's go to the next route so we don't waste time. The next route I want us to look at is what? Under enteral is rectal. Rectal routes. Rectal route. Here we see dosage forms like suppositories, enemas. Suppository enemas. Now, what happens in rectal administration? In rectal administration, the drug is administered through the what? The rectum. Through the what? The rectum. And in the rectum, they will be absorbed, some, not all, some will act locally, some will be absorbed across the rectal mucosa. Across the rectal mucosa. So this also has a partial avoidance of the first pass effect. Yes, but this depends on how we are the level of the insertion. So if you insert it upper, if you insert it a bit up, it can enter the worst portal circulation. So as you are doing that, targets not too up, but at least halfway. If it is too low, the suppository will fall out, but not too high, so it doesn't enter the what? Portal circulation. That's the point I'm trying to make. But basically that is anyway if your target is local. But if it's systemic, it's okay. If you get to the upper, it can enter through the systemic circulation. Am I communicating? Now, but the major thing is, what if that drug will have effect have first pass effect? So that means you should avoid portal circulation, not too high. Good. Now, what is the advantage? What are the advantages of these rectal routes? Yes, there are some drugs that can maybe if a patient is vomiting, yes, it has an edge as a way of administering a drug when a patient is vomiting. Then if a patient is unconscious, you can administer through what? Route what? Means. Sorry, through rectal means. If the patient is uncooperative, a patient may be a psychiatric patient can, once you're able to, hold the patient, you can force it, put it through the what? Anus. You can, if you will be able to hold the patient anyway. But generally, it's for uncooperative patient. Yes, it's a very good route of administration for such category of what? Patients. Then, it is also very good for local treatment. I think I mentioned that. It's also useful for local treatments, like patient with hemorrhoids or pie. Yes, it's very good for such patient. Such route is good for such patient. Even for systemic circulation, yes. Paracetamol. We have paracetamol suppository. Can someone give me an example of suppository used for hemorrhoids and pie?
Anusol.
Anusol, God bless you. Anusol. Good. Then for fever, for patients that have fever, for children, paracetamol, we don't have paracetamol as what? Suppository, even diclofenac. Even for constipation, you can also have suppository for constipation. What drug is used as suppository for constipation? Do you know anyone?
Miss Mag.
Constipation, suppository.
Okay.
What are you saying? It's not mismark. Mismark is
Bisacodine.
Bisa
Bisacodine.
Liquid paraffin.
Bisacodine.
God
Yes.
bless you.
So what
Suppository.
of liquid paraffin?
Liquid paraffin is not a suppository. It's not for suppository. Liquid paraffin is you take it orally now. Are you aware? You take liquid paraffin for constipation. I agree with you orally. It's not rectally. You take it orally, not rectally. So as rectally, you can use Bisacodil suppository. Yes. This popular brand. What is the popular brand there? There's a brand by Boringa Angelic. What is the name?
Ducolas. I use Ducolas. Ducolas.
Ducolax. Yes.
Yes.
Ducolax. Yes. That's the one by Boringa Angelic. Good. God bless you. So now let's continue. So let's look at what are the limitations of this rectal route. It has varied, just the same way the oral one has variable absorption. This one has variable absorption. Remember I told you, remember when we discussed suppository in your first year? I told you we discussed a lot of things about what affects the absorption of suppositories, what happens in the rectal area, the pH, the presence of fecal matter, and other things will affect it. So it has variable absorption. And another problem limitation is that it can be embarrassing. And it causes the patient some level of discomfort. Yes, some people don't even like to even put anything in their anus. Yes, the discomfort, it can cause them discomfort. And some drugs can irritate. Remember when we discussed suppositories, I talked about proscites. It can irritate the rectal mucosa and lead to what? Proscites, inflammation of the rectal mucosa. It can also cause it. So it can cause irritation of the rectal mucosa. Yes. So such drug that can cause such irritation should not be used as formulated as what? Suppository. Examples, I've talked about it before. Even fever, even what is it called? Paracetamol for fever can be administered rectally. Even diazepam for seizure control in the community, it can be administered what? Rectally. Any question?
Yes, sir.
Ask. Ask.
I have a question.
Ask.
So I want you to furtherly more explain that rectally to us, because no, there's another process that is called what's it called? It is those ones are insert through the vagina. What's the difference between it? Because I will not be missing rectal route, and I want to remember the other one that is being insert vagina. Are they the same thing?
No. Rectal is through the anus. Rectal is through the anus. Rectal is under enteral. Is that clear? Are we together? Please mute your mic. Mute your mic, please. Mute your mic.
Fiona.
Mute your mic. Oh, mute your mic. Who is this near student? Mute your mic. So you can hear me. All right. Now I said that rectal, if you remember what we discussed in suppository in your first year, rectal is different from vaginal. In terms of route of drug administration, rectal administration is under enteral, but vaginal is not under enteral. Okay, now I think let me now explain something further. I think I know where the confusion is coming from. You know, when we discuss suppository, I told you that traditionally Currently, each time you mention suppositories, people's mind we go to only rectal suppository. I said that suppository cut across both vaginal suppository, rectal suppository, urethral suppository, and different suppositories. But presently now, it looks as if suppository is limited to only rectal suppository. So vaginal suppository is also a suppository. But when you come to route of drug administration now, the suppository that we are talking about is not vaginal suppository. We are talking about rectal suppository, because the alimentary canal or the alimentary tract, gastrointestinal tract, start from the mouth to the anus. So anything that will enter through the mouth or enter through the anus is under rectal, enteral. That's why rectal suppository is under enteral. Vaginal is not under enteral. Is it clear?
Yes, sir.
So mute your mic. Mute your mic. Let's continue. So we are moving from enteral routes. Let's go to parenteral routes and other routes. In fact, all other route that is not what? Enteral. We are looking at all the other route that is not what? Enteral. So let's start from the first one. The first one I want us to look at is intravenous. Intravenous, IV. Intravenous can be bolus. It can be infusion. It can be bolus or infusion. Is that clear? So what I mean that it can be given as a bolus, just straight once. It can be given slowly. So all of them are under what? Intravenous. Now, so in intravenous route of drug administration, the drug is injected directly into the vein. Directly into the vein. And for immediate systemic circulation. So this route of administration has 100% bioavailability. It has 100% bioavailability because everything is entering the systemic circulation straight. So what are the advantages of this? It has the fastest onset of action. Fastest onset of action. Another point I want to note here is that it is, because of this now, it is valuable in emergency situation. As we discussed, as you answered on the first question I asked you at the beginning of this class. Then, it has accurate dosing, very important. Accurate dosing. And it's also suitable for large volumes, especially when you are talking about infusion. Large what? Volumes, fluid volumes. And it's also suitable for drugs that are poorly absorbed. If a drug is poorly absorbed through the gastrointestinal tract, no need formulating such drug as for oral use. Excuse me. No need formulating such drug for oral use. No need formulating such drug for oral use. Are we together? Good. Now, another point I want to make here is that it has its own disadvantages and risk because of the invasion issue. So not everybody, not all cultures, like anything that will like to be injected. So that invasive nature is a problem to some people. And there is also risk of infection. Yes. That's why you should be very, very careful when you are administering what injection. There are some people that they will go, if you practice this, or if you know someone that practice this, please caution the person. See somebody will go to the hospital and they will give cannula. The person will carry cannula and be jumping up and down, or scalp vein, and be going home, going to that thing is very, very wrong. It's a wrong practice. Don't do that. I know they may have the reason for leaving that. What is it called? The scalp vein or the cannula for the patient to carry it up and down. They may have any, but no matter any reason you have, that is wrong. That person can be infected because you don't even know where the person is staying, what the person is doing during the day. The person, you can, and of course, you know that such infection is going straight into the bloodstream. It's a problem, septicemia. So it's a very serious issue. So it can cause that infections. Yes, of course. Now, if care is not taken, abscess will take place. Even there can be, in fact, once it enters if there is any issue of reaction, and once the person enter the system, the blood streams, if you take orally and the person, you notice the person take maybe the wrong medicine, or you notice a lot, you notice reaction or hypersensitivity, the person can be saved because the drug will first get disintegrated and get dissolved, absorbed. Even using activated charcoal alone can mop up the mess, the drug in the stomach. But it's rare, you rarely save a patient that is being injected in such a situation. So there's rapid toxicity, especially when we have overdose. There's rapid toxicity. Then the effect may be short sometimes. The effect may be short. That's why sometimes they may start with bolus, then continue with infusion over time. All right. So now, as a technician, you have to verify before you give out anything. Be sure of what you are giving to avoid what issues. A lot of people will come into you for information with regard to compatibility of IV drugs, whether they are compatible with what and what they can mix with, whether they are compatible with it or not. And also, I think in your farm card now, you are doing farm card. You also do you also do rate of infusion and dilution. So this information, how to do all these things, is what you learn from your farm card. So knowledge of farm card, we make you a valuable source of information with respect to how to dilute, the calculation to be done, and what have you. Are we together? Now, this class was supposed to start by 3 p.m., but we started by 3:30 p.m. So, I don't know, by right, our class should be 2 hours, two hours each of the courses. But I don't know. I don't know how we go about it now to be able to cover if care is not taken. Anyway, let's keep. I will squeeze out time to see what you can do in your practical. Are we together?
Yes, sir.
Chisom,
Sir,
you
I'm
said
hearing you, sir.
you sent me a message. I want to understand what is your what is it called? What is your take in the message you sent me? see what I want to do here. Can you hear me?
Yes, I can.
I think let's just do do AUM. I will align with HOD.
Yes, sir. Yes, sir.
Align with HOD with respect to practical. I told you that our lecture now to the end of the semester is online. For now, my lecture with you will be online. There's a reason for that. You will still know with time. But I will align with HOD to know how the practical section. Hello. Must you talk? Must you talk? Be mature now. Mute your mic. Mute your mic. I'm talking with your class rep, please. Must you make noise everywhere? Now, so what I want to do is this: I will align with the HOD with respect to the practical. So whatever I decide with him, I will let you know with respect to the practical. Okay?
All right, sir. All right, sir.
But for now, I want to continue with AUM for now. So if I take a decision with him, I'll get back to you. Okay? Good.
Definitely, sir.
Right. So let's continue.
Wait,
Can
sir.
I ask a question?
No,
Sorry,
feel free.
please,
Ask a question.
please. I want to say something.
Okay,
Please,
sir.
mute your mic.
Hello? Yes.
Okay. The recording of the lecture, because we are unable to capture almost everything. The recording
You
of the
say what?
lecture, where
Don't
can we
worry, I
get
will
it?
send you the link. Don't worry.
Oh,
I'll drop the link when I'm
okay,
done,
sir.
okay? Don't worry. I'll drop
Thank
the
you,
link,
sir.
okay? Yes. All right.
Yes, sir.
Any other question? So someone wanted to ask a question.
Hello, sir.
Yes.
Can you hear me, sir?
Yes, I can hear you.
Sir, you were talking about hemorrhage the other time. You talked about some drug that you can use to arrest hemorrhage. I did not get that, please.
Sir,
No.
please, before you answer the question, I want to clarify something, sir.
Okay.
The online class will only be for AUM.
AUM for now, until I come up, I take a decision with respect to practical with HOD.
All right, sir. All right, sir.
Okay, Jamie, you said what? You said you asked question.
You were talking about the drug that we can use to arrest hemorrhage the other time. So I did not get that, sir.
No, it's not hemorrhage. It's a hemorrhoid.
Okay, hemorrhoid.
That is pie.
Fine, hemorrhoid.
Pie or pie.
Okay.
Yes. I talked
Okay,
about
that's when you
the
mentioned bizarcoline.
rectal suppository. No, bisacodil rectal suppository is for constipation.
Okay.
This I said anosol.
Okay. Anosol.
Yes, anosol. Yes, anosol. Okay,
Thank you, sir.
you're welcome. So let's continue. At least we still have approximately, when is the class supposed to end itself? Tell me, what do you want me to end? I'll end that time. If you want me to
Sir, by 5,
lecture,
sir.
if you want me to lecture till 8 p.m. I'm good.
No, sir, we schedule 3 to 5, sir.
Okay, so I should end by 5.
Definitely, sir.
All right, thank you. All right, so let's continue. Okay, so let's look at the intramuscular. Okay, intramuscular. You are familiar with this one now. From the term intramuscular, the drug is injected into the muscle. Okay, into the muscle mass. So when the drug is injected into the muscle, the drug is absorbed. There is absorption in intramuscular. Please note that when the drug is injected intramuscularly. Wait, sorry, when I was discussing intravenous, I mistakenly said abscess. Please, oh, it's not abscess. Is more is in intramuscular. Please, please note that point. Please, let's continue. Even though there may be some issues at the site of administration of intravenous anyway, but it's pronounced in the intramuscular. That is, if you don't do it well, okay. Now, okay, so intramuscularly, the drug is absorbed into the capillaries in the muscle mass, into the capillaries and the muscle in the around locally in that muscle area. So the drug is absorbed through the capillaries. Now, one thing, the rate of absorption of drugs through the intramuscular route. Please mute your mic. Rate of drug absorption through the intramuscular route depends on how the blood flow to that particular muscle. If the muscle has extensive capillary bed, then the drug will be absorbed faster around that area. But if it is sparsely vascularized, then absorption around that place will be slow. So it depends. So it also depends, apart from how vascularized the area is, it also depends on the nature, the formulation itself. Is it aqueous? Is it oily? Is it suspension? So this depend on, this will determine how it will be how fast it will absorb. This route of drug administration is suitable for when you need moderate absorption, moderately rapid absorption. And this intramuscular route can accept larger volumes when compared with subcutaneous. When we discuss subcutaneous, you will understand it better. It can absorb, it can take in more larger volumes when compared with subcutaneous routes. And the intramuscular also is very, very good for if you want to have, there's this formulation we call depot formulation that gives sustained release over time. So if you want the drug to be released over time, in a sustained fashion over time, intramuscular route of administration is the man. That's the guy you need. If you want it to be released over a sustained period of time. So, what are the limitations of this? It can be painful. Yes, it can be painful. And if you are not careful, especially, and even though yes, some use lidocaine anyway, but generally it's painful. Of course, that is why the need for lidocaine. So that painfulness has contributed to its disadvantage, its limitation. Because if it's not painful, there will be no need for lidocaine. Packaging lidocaine is extra cost and extra stress. So it's a limitation. Now, there's risk if it's not well administered, if it's poorly placed, there is risk for nerve injury, sciatica. Who has heard of Who have heard of sciatic nerve before? Have you heard of sciatic nerve? Have you heard of sciatic nerve before? Hello? Who have heard about sciatic nerve? Sciatic nerve? Nobody, okay. Do you know, at least some of you here are nurses, or at least so some of you are nursing technicians or assistants. Do you know why they will tell you to use your eye to divide, especially in the gluteus, if you want to inject through the gluteal muscles, gluteus maximum, and you want to, they tell you to use their eye to, some use their cotton wool and the spirit to divide the gluteus into four, right? Four quadrants, right? Do you know why you do? Okay. Some of you that are, even though yes, it is, please though, it is not your responsibility. It's not your training as a pharmacy technician or even a pharmacy technician to be injecting. That is not your training. No, don't go and say that I ask you to be injecting. It's not your training, please. I'm talking to those that maybe those that are net, because some of you in this class are registered nurses. These are the people I'm talking to. But it's also, you should also know about it too. But know it because it's important to know it, not for you to go and start injecting. But just know it, just the same way I know it. Please, those that are, they'll tell you that you divide the gluteus maximum into four, the gluteal muscle into four quadrants. So the nurses in the building, in the house, tell me, which quadrant are you going to inject intramuscularly? Okay, we would have a nurse here. Hello? Can you hear me? Hello?
We can hear you, sir.
We can hear you, sir.
Okay. Nobody knows. Nobody. Okay. You divide into four quadrants.
Sir, can I try?
Try. Where?
Okay, according to the way I've read it, or I guess it's the left side. I'm going to be using a layman language though, because I don't really know more about the.
No problem.
So I guess it's the left side.
Is it
I
upper
guess
or
it's the
lower?
left side of.
Sir, it is called left upper outer quadrant.
Good. God bless you. Left upper. That is anatomically superior-lateral, right? Superior and lateral. True of us. Anatomically superior and what? Lateral. You've done that. Have you done anatomical terms and positions? Superior lateral. That is left upper quadrant. Four quadrants, upper quadrant, the left of it. The idea is to escape a very important nerves that supply, they innervate the entire lower limb. Lower limb, that nerve is what's called sciatic nerve. So if you go to the medial or the right, left, upper or lower, or sometimes you may even go to the right lower. If you mistakenly go to this three side, you may puncture the sciatic nerve. And if that nerve is paralyzed, the entire lower limb, the entire leg of that side will be what? Paralyzed. Have you seen or heard a situation whereby somebody went to take an injection in the bum in the IM and end up paralyzing the entire leg? Have you heard of such situation?
Yes, sir. Yes, sir. Yes, sir.
Have you?
Yes.
All right. So This is a limitation when it comes to what? Intramuscular, especially if you are giving on the gluteal muscle. Be very, very careful about that. Okay. Then most times, if you are giving of course, it has variable absorption too. It has variable absorption. If you exercise, someone that exercise, if you are the type that exercise much, that means your muscle at work. You can the rate of absorption will be different from somebody that does not do exercise. The same thing I've talked about the blood flow. Blood flow there will also cause the variability in what rate of what absorption. So there is variable absorption. So it's a limitation, and also there is also, in fact, to self-inject is not that easy, except in some areas of the muscle. But to self-inject in your bum is not that easy. True of us. That is, if it's possible. So examples of drugs that can be administered through IM, we have vaccines, some antibiotics. As an example of antibiotics you can administer intramuscularly is what? Example.
Gentamicin.
Okay.
Gentamicin.
God bless you.
Ceftriaxone injection.
Okay. Now let's look at subcutaneous. Subcutaneous SC. We have 3 minutes to go. After subcutaneous, we end this class. Subcutaneous. That one is here is injected into the fatty tissue under the skin. It's not deep, it's not at the dermis. So fatty tissue under the skin, the subcutaneous layer under the skin. Then if it's injected there, it will be absorbed into the capillaries, and from the capillaries around us fatty tissue under the skin, it will get to the systemic circulation. Advantage is that it is easy for small volume drugs in small volume, and you can it is practicable to self-administer through subcutaneous injection, through subcutaneous routes. Example, insulin. Insulin can be injected. That's why some diabetic patients can actually inject themselves through subcutaneous routes. And it's also some drugs that have low molecular weights, like low molecular weight heparin, can be administered through what subcutaneous means. Limitation: subcutaneous have lower onset of action than intramuscular and intravenous. Please note that point. And there can be local irritation. There could be local irritation. It is not suitable for large volume drugs in large volume. It is not suitable for drugs in large volumes. It is not suitable for drugs in large volume. Are we together? Good. It's not suitable for drugs in large volume. Yeah, these are the words, limitation. I'll give you examples of drugs that can be administered through this route. Insulin can be administered, and now enoxaparin can be what administered. That is low, all these heparins can be what administered through this route. Any question? Any question? Any question?
Yes, sir.
I ask.
Okay, sir. It's not as if it's like a question, but not directly a question. You were saying some points before I cut off. You were like, a stuff that was under rectal. No, yes, I guess it was under rectal routine. You said before they give infusion, maybe said an injection must be given. I don't know I could not complete the statement.
No. What I said there was like most injections, both bolus injections, they have short duration of action. They act fast. Most intravenously, they act very fast. before know what's going on, they've done their work. That's why sometimes they will start with bolus injection and continue with infusion over time.
Okay. Yeah, that's what you said. I get it now. Thank you very much.
You're welcome. Any other question? It's 5 p.m. Any other question? Any other question? All right. In the absence of any question, I think we'll stop here. Please, I will advise you. I will advise you to, we've missed. I travel, so we miss a lot. We miss some classes. Please, always liaise with me to fix some other time, even if it's 1 hour or 1 hour, 30 minutes, to be able to cover. Is that clear? That's my advice to you. Okay? All right. So decide that on your own and let me know if the time is suitable for me. I will approve it. If not stable for me, I'll tell you when I'll be able to do that. All right. Thank you very much for spending 1 hour, 30 minutes of your life with me today. And God will bless you as you do so. As for the record,
Thank you very much, sir.
You're welcome.
Sir.
I will send the.
Sir,
Yes.
sir, this Chisum. So I don't know if I should send you the attendance that I have, people that attended the class, or you
Yes,
have
send it.
attendance.
Send it.
All right, sir.
Send it.
All right, sir.
All right. See you next time. Please, always. Huh?
Our lecture notes. So
You should do the needful now. Do the needful. You know what to do.
Yeah.
Yeah.
If what I want to job, you do